You are in tune with the nation's stations, ABS TV Channel 10, the GIS, and ABS Radio 90.5 FM. Proudly serving you, reaching more and more people every day.
Hello, good evening, and a warm welcome to another edition of House Calls. It's the regular staple Tuesday evening program here on ABS, devoted to bringing medical advice to you, possibly life-saving medical advice. We're not only interested in health care, though, here on House Calls, we're interested in something called wellness, the concept of wellness. To be even is not just the absence of disease or absence of sickness, but it is making sure that you are at your optimum. You're operating at your optimal. So that's what wellness is about. So this evening, we're talking about two NCDs, non-communicable diseases. All right? We've been talking a lot over the last 2 years about communicable diseases, such as, for example, COVID-19, the global pandemic. But while COVID-19 dominated the headlines, NCDs have always been pretty much here with us as well. So these are diseases such as hypertension and diabetes. Two of them that we'll be talking about this evening. And you will be absolutely surprised, possibly even flummoxed, by the extent to which these diseases are reaping a grim toll in lives here in the Caribbean. Diabetes and hypertension. So with us this evening, the doctor in the house is easily the very best placed to talk about diabetes and hypertension. He is Dr. George Mansoor, who is an internist and specialist in nephrology and hypertension. He joins us this evening to talk about all you need to know about the causes, the risk factors, the symptomatology of diabetes and hypertension, and crucially, the prevention, how you can prevent yourself having to deal with diabetes and hypertension. So, for the next 90 minutes, we urge you to pay rapt attention as Dr. George Mansoor unpacks and deconstructs diabetes and hypertension. Good evening to you, Dr. Mansoor. Thank you so much for being here.
Good evening, Mr. Burford. Thank you for inviting me to the now famous House Calls.
Yes, thank you so much.
So this has become a regular Tuesday night staple all around Antigua and abroad. So congratulations on a well-developed program.
Absolutely. It's a great team effort. Or thanks to our executive producer for making it possible. So let's start off with, even before we touch on hypertension and diabetes, just a little bit about Dr. George Mansoor. We normally introduce our audience to the doctor in the house. So just a little bit about your background and the extent to which you've, for example, been practicing so many years, and why nephrology and internal medicine.
Well, thank you. Thank you for asking me to do that. I think most people in Antigua and the Caribbean would be knowledgeable about myself. I've been a physician for about 35 years. I've worked not just in Antigua, but Barbados for an extensive period at the Queen Elizabeth Hospital. I've also did my studies in Jamaica. I've studied and worked in the United States for over 25 years, Scotland. So I've been around the block a few times and seen all the different changes in medicine that have happened and in our societies as well. And a lot of what we'll talk about today, I remember even as a student, where they were not as big problems as they are, today. So that's a little about me. I'm currently a consultant at the Mount St. John Medical Center, Sir Lester Bird Medical Center, in the Department of Nephrology. I also have my own practice in internal medicine and, general medicine as well.
Yes, yes. I mean, saying that you've been around the block is an understatement. You've spent, 3.5 decades is extraordinary in terms of the length of time that you spent. Anybody can spend in any vocation. And certainly in this one, you're pretty much saving lives. So congratulations on the length of time that you spent in. Why nephrology though, and why internal medicine? Because you could have gone into any other of the other specialties.
Yes, well, when I was in training as a house officer, a junior doctor, I was actually interested in orthopedics. And I found it rather difficult to get into that discipline.
Yes.
So everything happens for a reason, as people say, and it was a rejection, and here I am. And so life sometimes is built on a series of rejections. The important thing is to keep moving forward and trying to see maybe that's God talking to us when we get the rejection. He's redirecting us to a different pathway, so to speak.
Absolutely. When one door closes, another one opens for you.
Yes.
Dr. McDowell, you know him, orthopedic surgeon.
Yeah.
Yes, indeed. Good friend of mine. So there you go. You're introduced now to the doctor in the house. So hypertension, doc, and diabetes, two of the silent killers. We call them silent killers because they account for so many deaths here in this country, around the region, and in the Americas, and around the world generally. You have some statistics to talk with us about, but even before we get to the statistics, that's a definition. What is diabetes? What is hypertension?
I think in order to appreciate what a condition is, a disease process is, it's important to know what's normal or what is healthy. And so let's look at both of those in a rather simple way. Mm-hmm. Your body obviously needs sugar, glucose. And without it, we can't really survive. Sugar provides energy in the body. So it's normal to have sugar in your blood, so to speak, at a certain level. Mm-hmm. And the body has exquisite mechanisms to regulate it. A number of different processes regulate the amount of sugar that's in our blood. So if I were to take your blood right now and measure your glucose level, it'll fall somewhere between 60 to 100 on our scale that we use, which is a milligram per deciliter scale. So that's normal. That's a healthy person is in that range. Now, due to a number of factors that we will discuss later on, that mechanism of keeping the sugar within that range is a rather narrow range. If you remember, the brain can't survive for very long without sugar. So that's why if you have a low blood sugar attack, as many diabetics out there would know, you might start sweating, lose consciousness, etc. The brain can't go for long without sugar. But as these processes start affecting that regulatory system, the sugar starts creeping up. And let me take the opportunity here to explain something about diabetes, which is we also now not just talk about the sugar level. We talk about something called the A1C, the hemoglobin A1C. Patients out there know it because their doctors are testing it. But let me explain what it is so people can understand it. So normally the sugar in the blood being between 60 and 100 would undergo a reaction with your red blood cells and attach to it. So there's a certain percentage in a normal person that has this sugar attached to it. That's why it's called hemoglobin A1C. So normally it's about 5%. 5% of your red blood cells would have sugar. Now, as the sugar starts getting impaired, the processes that regulate sugar get impaired and the sugar starts climbing, the percentage of the hemoglobin that is attached with sugar will increase. And that's why we use not just a blood sugar to diagnose diabetes, but we use the hemoglobin A1C. So if it's 6.5 or greater, we start saying, well, that person has diabetes mellitus. Now, as you can tell, between 5 or 4.5 is normal up to 6.5. It may not sound like a big change, but it actually is a fairly big change because it takes a long time for the sugar to attach to the red blood cells. On average, the measured hemoglobin A1C reflects the blood sugar levels over the past 6 to 8 weeks. So it's actually, in many ways, better than the blood sugar because the blood sugar just tells you what the sugar is at this moment, whereas the hemoglobin A1C says, look, on average, your blood sugar has been this high the past 2 to 3 months.
It's like a snapshot over time.
Correct. And that's why it's so valuable to us to diagnose patients controlled. No, so that's an explanation of normal and abnormal for diabetes. So when it reaches a certain point, the sugar will be persistently elevated, and you can feel quite fine. As you said earlier, a lot of these processes that occur in these silent killers, you feel fine, and you don't feel any need to go to the doctor. So now let's talk a bit about hypertension, because these two conditions go together.
They're like siblings.
Yes, the processes that drive the sugar to go up are very similar to the processes that drive your blood pressure up. So obviously the heart is a pump. The heart is pumping blood around your body. Every time the heart pumps, there's a pressure exerted against the blood vessel. And that pressure can be measured. We see doctors and nurses measuring the blood pressure. And it's, in a healthy person, it's usually somewhere around 100 millimeters mercury on the top number, and up to 120, 125. So that range is the top number. And then the bottom number, it may be anywhere from 60 to 75, 80. Now, for the reasons that I mentioned earlier, and other reasons, lifestyle, different hereditary conditions, the pressure becomes higher. There is a need now for the heart to pump against narrower or stiffer vessels. So the pressure to get the blood around has to be higher. And again, it's totally unnoticed by the patient, and sometimes even the healthcare provider.
Wow.
Because they may notice a trend upwards, but not pay it any mind, because they would, blood pressure is such a variable parameter that we're sometimes never quite sure what the blood pressure is. So let me expand that idea a little bit more, because if I suspected you, Mr. Burford, had diabetes, I would say, listen, just go to the lab, get a set of blood work, get your blood sugar tested, and your A1C. If I suspected you have hypertension, there's no blood test that I can say to you, go and do this test, and I will know that you have hypertension. All I can do is ask you your history, and most of the times you're not having any symptoms. But the diagnosis of high blood pressure lies in the measurement, in the actual measurement of the blood pressure clinically. There's no lab test or x-ray or anything that's going to say, yes, he has hypertension or he doesn't.
You have to strap the thing on your arm and test your
and they measure
pressure.
your blood pressure. And then there's so many of these now that you can measure it at home as well yourself. And that is highly recommended, because any of these chronic conditions, it is really not enough to just say, well, I'm taking my medicine or I'm doing my exercise. You have to monitor yourself in order to know. You're seeing the doctor once every 3, 4, 5 months. What happens in between that time? You need to be monitoring yourself to know that you are keeping the condition under control.
Absolutely.
And luckily for us, patients can easily learn how to monitor their own blood sugar. They can easily learn how to monitor their own blood pressure. So these are very valuable tools. And increasingly, you see more and more people that are doing this, monitoring themselves to a certain point, which is good. Because sometimes you get complacent, and you might think everything is going well, and then, something like COVID hits, or you're busy doing some other things, and then 2, 3 years later, now you go to the doctor and there's problems on the horizon. So there are a lot of similarities between these two conditions, and they have similar risk factors, and they travel together.
Wow.
So you hardly ever see somebody just have high blood pressure. There always is something else the patient has. They have overweight, they have family history, they have other things that are also happening.
And that's why we're dealing with those two together, hypertension and diabetes together. So some people, for example, in the Caribbean, we colloquially say the person has pressure. I mean, just using the word pressure, or the person has sugar. Just using the word sugar. So we're dealing with blood pressure and blood sugar together in this edition of House Calls. Doc, just before we take our first break, you have provided for us, and by the way, Doc, like all the others who have been on this program, the distinguished medical professionals, he has done some slides that we'll be showing you later on in the program to chart for you so that pictorially you see what he's talking about. Just before we go to our first break, we want to share your slide about the prevalence of it, because it is frightening. COVID-19 has killed officially over 6 million people, although the figures are more like close to 20 million people around the world. You're going to look now at some figures for the prevalence of these two, blood pressure and blood sugar, i.e. diabetes and hypertension. We're going to bring up that slide for you in a short while. While that slide is coming on, Doc, the importance of, not quite this one, but the one about, for example, the prevalence around in terms of how it's affecting the Caribbean and this side of the world. Why is it so bad in the region? Why is it so prevalent here?
Well, it's a worldwide phenomenon. The epidemic of hypertension, diabetes, the NCDs is a worldwide phenomenon. It's not just a disease of developed countries anymore. It's more a disease of everywhere. And you find large middle-income countries, India, large parts of Africa, Middle East, the Caribbean, the Americas. We've caught up with the first world, so to speak, because a lot of our population has now developed these conditions or are at high risk. It's really another question to sort of dig into why that has happened, and maybe we'll have some time later in the program to get behind the curtain to find out what's really driving this epidemic worldwide.
Absolutely. We're going to show you that slide when we come back from this our first break. We're going to take the break first, and then look out for that slide when we come back about the figures in relation to both diabetes and hypertension. It will be stark, and it will shock you. The program is called House Calls. It's sponsored by Sagicor, with the kind compliments as well of our other partners, Pink Mongoose, as well as A.G. Morgan. When we come back, Dr. George Mansoor, who is, as we said, a consultant nephrologist and internist or specialist in internal medicine at the Celeste Bird Medical Center, will talk with us further about the risk factors, causes, treatment, prevention, screening for these two, who he says travel side by side like siblings. You hardly ever find one without the other. When we come back, much more on House Calls. Stick around.
Life moves fast. Be prepared with Sagicor. Learn more at sagicor.com.
This week on Conversations, we speak to
Sir David Showell, owner of Showell's Toys, Gifts and Housewares.
But that was where those things started, because everything happened there. I'll tell you something that probably wouldn't happen to them. Forgive me for saying this, I hope.
Conversations, a short yet stimulating, revealing look at the life of prominent Antiguans and Barbudans. Join me, Natalie Clark-White, for Antigua and Barbuda's prominent people stories, and be inspired.
Seeing is experiential. Seeing is everyday life. Seeing is style, class, and sheer sophistication. At iMobile Vision Care, we offer state-of-the-art lab technology and the widest variety of quality eyewear from the biggest brands to suit your lifestyle. Stop by our offices at Dr. Rosalie Drive, Lower Gambles to get a comprehensive digital eye exam, or call us at 562-7823 and ask about our optical care services. iMobile Vision Care. See and be seen.
Thank you so much for staying with us. We welcome you back to House Calls. The program this evening is focusing on hypertension and diabetes. Dr. George Mansoor is the doctor in the house, as we said, consultant in internal medicine and nephrology at the Celeste Bird Medical Center. As we said, internist and specialist in nephrology and hypertension. We're discussing how these two, hypertension and diabetes, chronic diseases, non-communicable diseases, which, by the way, are accounting for so much disease and death in the region, how we can tackle these two more effectively. Dr. Mansoor, so we're going to go through your slides now, which, as I said, make for telling reading about the impact of these two. So let's start with our first one, because, as I said, we're going to get to that slide now about the mortality. Here we go. Here, Doc.
Yeah, so this first slide is just a description really of the problem, which is the high prevalence of non-communicable diseases in the Caribbean. So the NCD mortality in the Caribbean is really one of the highest in the Americas region. And it accounts really, these account for the majority of premature deaths. That is, people who are dying well before the expected survival. And we are seeing somewhere around 40% of these deaths occurring prematurely. In other words, while they are affecting persons who are older, they are also disproportionately affecting younger persons. So that's why, so you can imagine if a person suffers a complication or disability or death from one of these, they've lost 30, 40 years of life and productivity if it's in their 40s or 50s.
Absolutely.
So if we go to the next slide, we will be able to look at some of the causes of premature death. And these are common situations. Heart attacks, everybody's familiar with that. Of course, diabetes is a big cause, stroke, and cancers. Now, one thing to take away right away is that hypertension and diabetes, while they are diseases in and of themselves, they're also risk factors for the complications. So while a person can die of diabetes, it's more likely that the person is having problems with cardiovascular system or the kidney or the eye. Usually the eye problems will not cause you, of course, to die, but heart attack, stroke, these things can cause you to die and can cause you to be disabled and impaired.
Right.
So these conditions all fall into that category of cardiovascular disease. They're all affecting the blood vessels, the diabetes, the hypertension, the cholesterol. All of these fall under one umbrella, so to speak.
Which affect our circulatory system.
Exactly. And of course, our entire body is supplied by the circulatory system. So hence, you can see that depending on what part of the circulatory system is affected, you could suffer one of many different complications.
Absolutely.
But I think there's also a flip side to the coin, which is we do know that today, 2022, we have so many good ways of tackling these conditions. And it's not just the healthcare team, really. The patients themselves, if they are involved and are motivated, you can actually prevent the vast majority of these complications. It's not a given that these things have to happen.
Yes.
And so across the entire spectrum, you could think of ways that we might want to prevent people from getting the conditions in the first place. That's great. And that is something that has to be done in policy, meaning it has to come in policy, start in schools and early adulthood and so on, because the diseases evolve over a period of time. So if children, adolescents, they are the ones, they're leading the bad lifestyle, they're gaining weight and all these things, eventually that's going to translate when they become adults into these conditions. But we do know that there are effective ways to counteract these trends.
And we're going to come to that. We're
Yes.
going to come to that a bit later on, where we deal with, for example, prevention and so on, and screening. Doc, the importance of, we're going to come to the age issue, but from that slide, you're saying premature deaths and the age threshold that you're using for premature deaths, the one before that, the slide before that, the premature deaths, you're looking at under 70 years. You know, because life expectancy is around 70 or a little over 70 thereabouts. So anything before 70, you're thinking that's a premature death.
Correct.
Except if, for example, if it's a traffic accident or something. So in other words, if you're getting...
It's still a premature death, even if it's caused by an
whatever it is,
accident.
right, but in terms of from the disease, actually.
Yes.
Right. So for the majority of people, or for significant numbers of people who die in the region before 70, some of these non-communicable diseases are attributed, are the cause for that.
The majority.
Wow.
The majority of people who are caused by those conditions. Now, we're not going to be talking about cancer today, but cancer also falls into that bucket of the non-communicable diseases. And if you go to the graphic, we have a graphic on one of the slides that shows the risk factors for diabetes, but I just want to illustrate something, which is that those risk factors are the same for all these conditions. And that's why they all travel together, whether it's hypertension, whether it's diabetes, even some of the risk factors for cancer are the same. So it's not surprising that the increase that we are seeing in the region and worldwide. Yes, this is the graphic, and you can see here risk factors for type 2 diabetes, which is a type of diabetes that occurs in adults. And you can see lack of exercise, being overweight, family history. Well, that's immutable. You can't change that because and then unhealthy living. So these are really the key factors driving a lot of the premature deaths that we are seeing. And so we have to ask ourselves really a question, which is how can we address these factors, not just at an individual level, but as a region, as a society. And you will see across the entire region that steps are being taken to address these factors, whether it's through changes in the way and availability of easily processed foods, etc. Of course, that's not a medical area, but I'm just saying that a holistic approach is necessary in trying to tackle these risk factors that we are talking about. It's not enough to just say, well, okay, we have the hospitals, we have the clinics, we have the medicines to treat these conditions. We really have to aim for trying to prevent them so that in 10, 20 years we can say, look, we are noticing now that the number of cases are going down.
Yes.
Our efforts have borne fruit. And you know, some of these may take some time to bear fruit. Prevention is always takes longer than other things. And so one has to be patient when one is instituting preventative measures, because it may take a little while, a few years, before you see the benefits.
We remember the old adage, Doc, that an ounce of prevention is better than a pound of cure. In this case, you can't cure a lot of these chronic diseases, but essentially you get the picture. All right, so we go back to our slides. I'm still flummoxed by the extent to which our societies are being just absolutely disrupted by these non-communicable lifestyle diseases. A lot of them, by these, the risk factors, people wake up in the mornings, they drive to work, they then go to their desk and sit for an extended period. They then go at their lunchtime to purchase something salty or fatty or sugary, most times processed foods, and chicken that you can squeeze it and see the fat just draining out of it. You know what I'm talking. And then you come back to your desk and you sit again, and then you drive home and you sit in front of the television for an extended period again, or you sit or you lie down and you are on your phone surfing or on your laptop or something, and then you go precisely with a piece of chicken while you're doing that, and then you go to bed, and you go and do the same thing over again tomorrow. That seems to be where the challenge is. Our lifestyles are literally killing us.
Well, these are lifestyle diseases. That's the other term for the non-communicable diseases, because our lifestyles have a lot to do with what's happening. Genetics is there too, if you have a family history and so on. But lifestyle is the key thing. Our lifestyle has totally changed in the last 30, 40 years. Everybody drives a car. Very few people walk anywhere. There's more stress in the workplace, in the family. So all these things. If you think about, just zooming out a bit to the pillars of health, there are many, many pillars of health, but to me there are three big ones. One is how you eat, what you're eating. Two is getting adequate physical activity. And thirdly is getting adequate sleep. So sleep is sort of a forgotten thing. We just go to sleep, we wake up, and that's it, it's over. However, it's very important that one sleeps adequately. And there are many professions where I have seen persons over the years where working night shift and other situations disrupts sleep. And sleep is your restorative period. Sleep is when your body heals itself. So if you're not getting that, you're not going to be healthy. So whatever damage you do to yourself during the day, during sleep, your body tries to heal it. And the body has an intricate healing system for the vessels called nitric oxide. And during sleep, the nitric oxide is working away to try to fix whatever you caused during the day. So you can imagine if you're not eating, if you're not sleeping well, the opportunity for healing is not there. And so these three things, of course, there are many others, mental health, a lot of other things, but to me, those are the most three basic pillars of health. Any one of those pillars gets disrupted, the stool goes off balance.
You're saying what you eat,
What you eat,
how much exercise you
being
get,
physically active, and sleep.
and sleep.
Any of those three is like a tripod. A stool can't stand up on two legs. So we really need to look carefully at how we can incentivize people to follow and the things that we're recommending, not just saying to them, okay, I want you to do X. How can we incentivize a patient to achieve those goals that we would like for them to do and that they have bought into? They have said, well, okay, I'm willing to try, but we need another step, which is how do we get it done? Because frequently the patient keeps coming back and they're still not getting the results that they want. So we need to be creative and figure out ways. And this is where the behavior therapists and the people who understand human behavior come in, because they can give ideas to medical professionals, nutritionists, and so on, how to achieve those things. It's not a simple matter of saying, well, you know, lose 20 pounds and come back. No, it doesn't work like that. The only people who do that are the vets, the military people. You tell them to lose weight, they do it.
Yes.
But that's a different story.
Yes, we're going to come to that a bit later on. And then, of course, the epidemic of bad eating is an epidemic by itself. We're going to come to that in terms of do's and don'ts a bit later. But let's go back to our slides. Our control room was so gracious enough to assist us to get through our slides. Dog, take us through, please.
Okay, so again, we talked about hypertension. Now, hypertension worldwide, it is actually the leading risk factor for death. It may sound, the burden of hypertension worldwide is great. Now, why do I say that? If you look at the prevalence of hypertension and diabetes, while diabetes is very common, if you look in Antigua, if you stop 3 people right now on Market Street who are adults, there's a good chance one of them might be a diabetic or what you stop. So it's somewhere around 20%, 15%, somewhere around there, depending on what part of the Caribbean you're in. Now, the prevalence of hypertension is much higher than that. And in some countries, it's as high as 50% of the adult population. 50% of the adult population. So you can see why hypertension, because it's affecting so many more people, exacts this notoriety for being the leading risk factor for death. Wow. Now, also, diabetes prevalence is very high in the Caribbean, and it's higher than many other countries. So we really need to sort of start tackling these things in a cohesive way, having orientation and alignment between private doctors, hospital, the polyclinics, the nutritionists, in order to achieve those goals. And perhaps in some ways we need to learn from ourselves. We have to go back and say, well, how did we get rid of all these infectious diseases? And the answer was we had a very robust public health system. There's nothing different about these chronic diseases. They are susceptible the same way to public health intervention. So as a region, we need to start looking at creative ways to monitor and patients who have these conditions to see if we can reduce the complications. Yes. A similar approach could be taken for prevention. In other words, not waiting until they become diseased, but trying to tackle things at a much earlier phase.
So focusing on wellness
Correct,
issues.
exactly.
In other words, not just the absence of disease,
right,
but ensuring that you prevent the disease,
correct,
the wellness aspect.
Yes.
All right. So again, if you could just think on those for a second, just cogitate on it, that diabetes and hypertension Hypertension being the leading risk factor for death globally, diabetes in the Caribbean double the global rates. Frightening. Let's continue with the slides while we talk. We're going to come back to that a bit later on, though. Our next slide will take us through.
So this is an illustration of how common these conditions are. These are surveys in CARICOM countries. So somewhere around, depending on which territory you're dealing with, 10 to 25% of adults have diabetes.
Wow.
And somewhere around 20 to 50% suffer from high blood pressure. So they're very, very common. Now, one of the difficulties we have is both of these diseases have a very silent phase, meaning a person can have these conditions and not know for many years while the damage is being done. And that's why it's critical with the availability of medical care in Antigua, availability of blood pressure machines, glucometers, that people should avail themselves of it. They should be able to check their blood pressure at home, at work, at offices, because many times persons may have been told their blood pressure was high when they cut their foot and went to the doctor, and then it slipped for the next 5 or 10 years.
Nothing was done.
In the meantime, yes, damage has been done, and at times to a point where it's irreversible. For example, we see patients who have hypertension who develop kidney failure, and that they show up with that, and we're saying, well, what happened in the last 10 years? You knew you had hypertension. You didn't go to the doctor. I mean, I find it amazing because there's so many medical facilities in our region now. Every island have clinics, they have doctors, hospitals, and yet a person can go for 10 years without ever having their blood pressure checked. It shouldn't be like that.
Amazing. So you're saying both, it's a working in tandem between people being able to check themselves,
yes,
being able to go to the public health system as well, or even the private health system, and to make sure that the access is increased to healthcare. But again, those figures from CARICOM are frightening. Why is it, ask yourself for our audience, why is it that we're having such high levels of prevalence of these two diseases? Higher than the average globally, especially for diabetes, double the global average. All right, before we go to our next breakdown, we're going to go back to about the next two slides, because those will also help us to further our understanding of these two, why it is that we're dealing with them together, because they operate together, as Doc said earlier. Our next two slides will walk us through.
These are just graphs, and it might be hard to read, but they just show you the death rates from hypertension in some of the Caribbean islands, and these are per 100,000 persons, and you can look on the right, you see the international same sort of figures, and if you look on the left side, you'll see how high they are compared to the ones on the right. So we are experiencing quite a lot of death from hypertension, and these are figures that are adjusted according to population, so it's not just, well, that the population, that's why they say that they are standardized.
Yes.
So it's a per unit population. So for every 100,000 people, for example, in Guyana, there's 45, 46 people who are dying from hypertension per year. And
these are death rates?
Yeah, these are death rates. You can read that going across, so you can see that the rates are quite high. In the USA, for example, look at how low it is, even though they have a lot of these conditions, the UK, Canada. So we need to move those lines, those bars down, way down to where the others are, even eliminate them. So hypertension is one of those, I think, that there's so many people out there who have hypertension who are not aware of it, and therefore we are seeing a lot of the complications. So there are a lot of steps that what one could take. For example, encourage more screening, and you do see a lot of this happening now in Antigua and elsewhere. People do screenings for hypertension. We had one at the hospital recently where we had for World Kidney Day. But I think each person has a responsibility to themselves and their family to, visit a doctor or nurse or healthcare professional once every year or two, get a checkup, see what's happening. It's not unusual to see patients who come in for a checkup and they haven't seen somebody in 5 or 10 years, and they really have problems.
Wow.
Yes.
Because they weren't following.
They weren't following, or they felt fine. That's
Yes,
the problem.
yes.
You cannot wait until you start feeling sick in order to detect these conditions. You have to do it before you start feeling sick.
Especially our men, we have to get our men to do these wellness checks because for some strange reason, men have a sense that it's a machismo kind of thing, that they're not supposed to go to the doctor because it shows that they're somehow weak or soft. It is perhaps one of the most sort of ridiculous kind of views that men have. Anyway, you could call it toxic masculinity, whatever you want to call it, but it is also counterproductive, counterintuitive. Doc, we want to take one more slide and then we go to our next break.
Sure.
But again, those figures are pretty frightening. Antigua and Barbuda is, if you could, just before we go back to that slide, Damien, if you could go back to the one that we had before with the death rates in terms of, right. So Antigua and Barbuda looking
it's sort of midway.
Right, there you go. We're on about just under 30 per 100,000 from hypertension.
Yes. Yeah. So one other thing to keep in mind that this data is culled. In other words, that frequently when a mortality can be contributed to by many factors. So as I said before, the person might have hypertension, they might have diabetes, heart disease, and so on. So, but this is looking specifically at people who just have hypertension. So it's an interesting sort of situation, but we need to move those bars down so that the death rates are much lower. They're significantly higher. You can see Guyana now having one of the highest death rates from high, and that is largely because of lack of detection of hypertension. Your comment about males is spot on. In fact, if you do screenings for hypertension, you will find that there's a 2 to 3, for every one female who's discovered who has hypertension that didn't know about it, there's 2 or 3 men.
Wow.
So there's a lot of us out there who have hypertension and don't know it.
Frightening. So while you're looking at those figures, or the next slide actually was what we covered before, but we just go back to it, right, because again, those are the challenges that we're having. Lack of exercise, overweight, unhealthy eating, family history, that you can't do anything about because you can't do anything about who your ancestors are, but the other 3, you can do something about them, especially unhealthy eating and lack of exercise, which actually feed into the overweight part. We're going to come back. When we come out, we'll turn our attention to more of those issues about diabetes and hypertension. More, for example, about the types of diabetes, type 1, type 2, how do you know the difference, the screening issues, when should you start screening, at what age, so on. All those issues will be discussed when we come back from this break. The program is called House Calls, sponsored by Sagicor, with the kind compliments as well of Pink Mongoose and A.G. Morgan. Let me show you what Pink Mongoose has done for us, a kind of close-up shot of what Pink Mongoose has done for us. Absolutely magnificent floral arrangement, as per usual. But each week, they manage to outdo themselves. For some way, they manage to outdo themselves every week. You might have just thought each week, man, they can't outdo that. It has happened to surprise you the next week. That is absolutely resplendent. When we come back, much more on House Calls. Stick around.
I had a really good time tonight.
So did I.
Life moves fast. Be prepared with Sagicor. Learn more at sagicor.com.
Let's get social. We're ready to connect with you. Find us on Facebook. Do you tweet? We do. Send us a tweet. Connect with us on Instagram. Keep up to date with news and more at www.abstvradio.com.
Welcome back here in tune with House Calls. Dr. George Mansoor is the doctor in the house. Do you know if you have diabetes? Do you know if you have hypertension? Well, if you don't know, tomorrow could be the time to check. All right, we're going to talk about screening a bit later on as well. Dr. Mansoor, let's finish up the slides and then we'll talk about a few other issues that don't come out in the slides. Our next slide will take us through more information. Here we go now.
Okay. So this slide is really just to give you the different types of diabetes. It's not, so we have type 1 diabetes, and this tends to occur in younger persons, children, and it's a different process. Remember earlier we said that something perturbs the regulation of blood sugar. In this case, insulin, the cells that produce insulin in the pancreas, are destroyed by an autoimmune condition. And that results in a deficiency of insulin. Insulin moves sugar from the bloodstream into the cells of the body. So if insulin is deficient or low, the sugar will increase in the bloodstream because it cannot get into the organs and cells that need it. So that's type 1. That's a much less common type of diabetes. Somewhere around 5 to 10% of all diabetics have type 1 diabetes. Okay. And they usually present early with symptoms. The type 1s tend not to have a long silent period because they get sick and they present to the doctor. So that, in a way, you could say that's a good thing because then they get attention very early in the process. Now, type 2 is the more common type of diabetes, and this occurs really due to insulin resistance, meaning you're producing a lot of insulin, but the tissues that insulin is knocking on the door to push the sugar in, they're not opening the door. And that's what the resistance means. So exercise, losing weight, all these things, and a lot of medications, they actually help to open that door, to move the sugar from the bloodstream into the organs and cells that need it. And so there are many factors that are associated with insulin resistance. Being overweight is one of those, and hence that's why being physically active is a very, very important aspect of not just preventing diabetes, but also treating it in order to maintain the blood sugar. So that's the most common type of diabetes, type 2. So when you hear somebody say, I have sugar, they're talking about type 2 diabetes if they're an adult.
Okay, right.
Yeah. Then there's one called gestational. That's diabetes in pregnancy. And obstetricians are very attentive to this one because it has effects on the mother and the child and the baby. Yeah. So frequently the pregnant woman would undergo screening for this condition in the second trimester. And it can be treated in pregnancy. Now, gestational diabetes needs to be managed correctly in order to have a successful mother and child at the end of the pregnancy. But also it is something that the mom would have to be careful of because it's a sort of a warning in a way that down the road that person might develop diabetes, and hence it would be very good for that person to think of it that way and take steps to avoid gaining a lot of weight and so on down the road so that they don't become diabetic. It's almost like they get a bit of a cheating card. They know that, hey, I'm at more risk than this other person. Yes, so that's good for them because they can take the steps necessary. Now, if you follow some of the women, if you follow them over a period of time, say you follow them for 5 years or 10 years, a large majority of them do become diabetic. Wow. The few who don't are really the ones who do what I just said, which is they realize, hey, I'm at risk. I'm going to make sure I get back to my weight that I was before I became pregnant. And any future pregnancies, they try to do that. And that's really the best predictor of remaining non-diabetic if you've had gestational diabetes. That is, being able to maintain your body weight as it is, rather than having this sort of staircase phenomenon in a way where with several pregnancies the weight tends to go up.
Let me ask you, gestational diabetes, how often, or can it really just segue into, let's say, type 2 diabetes? Or does it stop when the woman gives birth?
Well, yeah, no, that's actually what I was explaining, that most of the times it resolves after the baby is born. However, the women who have gestational diabetes, they are at very high risk later on for developing type 2 diabetes. So, and if I see someone who gives me that history, I always note it very quickly and I underline it because I want to talk to that person, say, look, you've been given some special powers. You know that you're at risk for diabetes, so you're going to have to start doing this, this, and this in order to prevent it. That's different than another person who may not have developed it, who is destined to become diabetic. They have not been given that
advanced
that
knowledge.
whisper, so to speak, that,
Yes.
that's the case.
Indeed. The final one, Doc, is secondary diabetes. Talk to me about that.
Yeah, this one is much less common, but it's primarily due to the effect of medications and so on. It's not a common topic, but just for completeness, we always put that in. For example, if you take steroids and so on, they can precipitate diabetes. But by far, the vast majority of people who develop diabetes have type 2 diabetes or adult onset diabetes mellitus.
Okay, all right. Our next slide, Doc, will take us through a few other issues that you want to talk with us about.
Yeah, so these chronic conditions require a model of care that should be different, I would say, than other conditions. They require, it's not just the doctor who's really the main person trying to manage these persons. It has to be the full healthcare team, the nutritionist, the ophthalmologist. You know, there are a lot of different people that would be involved in the care of a person with diabetes or hypertension who have complications. And you can see around the outer ring are the medical persons, the different specialties that can be involved in the care of these patients: kidney doctors, neurologists, obstetricians, primary care doctors. They are particularly important because they manage most of the patients who have diabetes. So they're critical in our healthcare system. Vascular surgeon who may deal with circulatory issues in the feet. Ophthalmologists, of course, we know that diabetes has a propensity to cause damage in the eye and the kidney, as well as circulatory problems. And like a number of other things, it's critical that this damage in the eye be detected early when it can be treated. And once that is detected early, treatments can be given to prevent further deterioration. Sadly, we see too many patients who present when the complications have occurred. They've had bleeding in the eye, they've had loss of vision, and so on. So that outer ring are the medical professionals, but closer to the patient where it says client, that's the person there. And you can see all the other people that are much more important perhaps than the doctors. It would include podiatrists, people, nutritionists, dietitian, nurse, educators, pharmacists, mental health professionals. All these people, to me, are much more important than the doctor. The doctor spending 5 minutes with the patient, you know. Whereas these persons, they are digging into the person's lifestyle, giving them advice. And, you know, once a nurse said something to me which I never forgot. She said, doctors treat diseases, we treat patients. And so there is some truth to that, because you're not just treating a disease, you're treating a patient who has a family, they have children, they have their job. So one has to get into that aspect in order to manage these conditions. You can't just treat the disease, you have to treat the whole patient, and perhaps sometimes even their family, in order to get to good results that you want.
That's, in terms of putting it in that graph, shows the kind of milieu of treatment and the modalities of treatment, how complex it is, and how it is that all of these different stakeholders have to work together. I think we have about a few more slides. Our control room will walk us through those. Actually, one more, and then we'll be able to take a few other questions. Remember, we're going to take your calls a bit later on, in another 5 minutes or so. Doc, this one.
Yeah,
please.
well, this is one really. Just shows you the kind of tests that we do for diabetes. You remember earlier I spoke about doing a blood sugar test.
Yes.
And so we can make a diagnosis of type 2 diabetes if the RBG is the random blood sugar. So if you're not feeling well and you're having symptoms and we test your blood sugar and it's over 200, we can say you have diabetes.
Okay.
If, however, you're not showing any symptoms and we do a fasting specimen like people do to go to the lab, if it's greater than 126, that is a cutoff for diabetes. So, and then remember earlier we talked about the A1C test, the hemoglobin, that if that is 6.5 or higher, we can also say that you have diabetes. So those are some of the tests that are done in order to diagnose the presence of diabetes. Patients don't have to know these, but certainly doctors and nurses and so on would be quite familiar with these numbers.
Doc, do you need all three of those to be aligned, or
No.
any one by itself?
No, they don't have to be aligned, but they frequently will be.
Okay.
They always tend to track together, as I said, because the sugar level is what drives the A1C level to be up. So there is a very tight relationship between those two things.
So somebody comes into your office tomorrow morning because
Yes.
they're watching this show and they say, wow, you know what? I haven't done a blood sugar test in a while, so I'm going to
Yes.
check with Dr. Mansoor. You would do which one first? You do the first one, the RBG, the random blood sugar first?
Well, if they're having symptoms, I would do a blood sugar in the office, yes. And if it is over 200, then I can, with some certainty, say, look, you look like you really have diabetes.
Okay.
I'm going to send you to the lab to do an A1C test. And usually it will confirm it. It's hardly ever not so. The important thing to note, though, is that the sugar doesn't just one day you get up and it goes high. It's been creeping up and over the years. And the sugar doesn't stay constant the whole day. Of course, when we eat, the blood sugar will go up quite a bit, then come back down. So if we're eating 3 meals a day, the blood sugar will be fluctuating after the meals and then come back down. One of the earliest things that's seen in patients who are destined to become diabetic is that it takes much longer for the sugar after eating to come back to normal. And sometimes you will see patients where the fasting blood sugar is okay, but the A1C is high, and you're scratching your head. So how does it? But it's because the sugar level stays high after eating for several hours and then comes back down. So when the patient is fasting, it's reasonably good, but the long high sugar after eating increasing the hemoglobin A1C. So we use both of them, and it's all depend on the individual situation.
So, and the A1C kind of gives you a trend over time.
Correct. It gives you a much longer picture.
Yes.
Because you do see that. You might check a patient's sugar is high, and they say, well, it's because I just ate whatever, or I ran up the stairs. And you see the same thing with the blood pressure, by the way, which is you would see a patient in your office or at a screening, and the pressure is high, and then, the patient is a bit concerned. They say, well, they find a reason. Sometimes the doctors also find a reason to explain away the blood pressure, but one shouldn't do that. One should seek a way to recheck the patient in the not too distant future. So if it is really just elevated because of a particular circumstances, that can be discovered. It should not be an assumption, because if the assumption is not true, the price is too high, because you're missing a patient who may actually have high blood pressure and who may not seek medical attention again for a while. So every interaction between a patient, and the healthcare system should be an opportunity to measure the blood pressure, no matter what they come for.
Just measure it as a routine.
Yes. Every patient that walks into my office has their blood pressure checked, their weight, their pulse, and I keep it in my records, because the patient might come further and say, well, hold on, listen, your weight is going up and your pressure was so good last time. Why is it a little bit higher now? So there is a time period during which these things are increasing, coming close to a diagnosis. That's when we want to pick it up. That's when we want to institute the steps that we recommend, versus waiting until they've reached that diagnostic threshold to say, well, you have type 2 diabetes or you have hypertension. One other thing I would say, Mr. Burford, is that we need to stop talking about a little sugar and a little pressure.
Yes.
Or say that the doctor told me I have a little pressure. In other words, they're saying, the doctor think I have it, but I don't.
In other words,
so,
that's what the doctor says.
So that's right. So,
Yes.
and that absolves the patient of any responsibility because he said, well, the doc. But you know, we need to take these conditions more seriously in terms of that. If a doctor has told you have high blood pressure, even if they said it was mild or whatever, make sure that you follow whatever steps are recommended and monitor yourself. That last part, you know, verify. You know, verify for yourself that your readings are good. Don't just feel, well, because I feel good, nothing is happening. That is not the right way. And as I said, Medical Benefits offers glucometers and testing strips for blood sugars, and home blood pressure kits are readily available. There's no shortage of them, and they're relatively inexpensive. So in Antigua, every household should have a blood pressure monitor and a glucometer that they can, even if nobody in the house has, you know, hypertension or diabetes.
We're going to take our final break. And when we come out, we're going to get your calls in. So 4622996. I know that you're chomping at the bits to call. 4622996. When we come back from this break, Shakespeare said in Julius Caesar that there's a tide in the affairs of men, which taken on a flood leads on to fortune, amid all the shallows of his life are bound up in shallows. Meaning, strike while the iron is hot. In other words, take the opportunity when it arises. We have to catch that these two matters, hypertension and diabetes, when the time is right. If we, as Shakespeare said, omitted, it leads on to miseries. In other words, there's a tide in the affairs of men, which taken at the flood, in other words, taken at the right time, leads on to fortune. Omitted, it leads on to misery. Diabetes and hypertension are not much different. You have to be able to catch them early or even prevent them. So when we come back, much more on house calls. We know the calls are coming in already. Right after this break, we'll take our first one. 4622996. Stay with us.
Sunny Sunday music to chase away your night blues. Neo soul mixed with a whole lot of jazz. Fine art. Join me every Sunday evening from 6 to 10 p.m. and let's paint music in the night air. Press the refresh button for a new week. It's Natalie Clark White. That's me, Nat C. ABS 90.5 FM. The art in soul and all that jazz.
Welcome back. You're in tune with House Calls. Let's go to the telephone lines first for our first caller this evening. Good evening. Thank you so much for joining us on House Calls. Go ahead, please. Good evening.
Hello.
Yes, sir. Go ahead, please. You're on.
I'm not hearing you at all.
Good evening, sir. Let's listen to your telephone, not to your television. You're on. Go ahead, please.
I am not hearing you. I have a problem hearing you.
All right. We'll ask you to hang up and call back. Perhaps there's a little challenge in the line, so I'll ask the caller to just hang up and call us back. 4622996. Doc, when should an individual start to screen?
Well, if there's a family history of diabetes, or if a person is overweight, they should really do it once they become an adult, in my opinion. And you can do it every year or every 2 years as time goes on. That's fairly easy to do. It's not an onerous burden on the patient.
Okay. And throughout your practice, throughout your 35 years, the youngest person you've seen with diabetes or hypertension?
Oh, well, we can see children who have hypertension and diabetes.
With type 1, though?
Yes, with type 1 diabetes, and hypertension as well is seen in children. It's much less common. However, we are seeing an increase in the presence of hypertension in adolescents because as the body mass index, the weight of the adolescents have increased, so has the blood pressures in the adolescent. That's why any intervention to try to prevent these conditions has to happen in the schools, probably in primary school and all the schools, so that the children can become more aware of what the problems are they face down the road And I see that happening in many countries and in many places. And it's a very important step to take, along with the other steps that are necessary, the policy steps that were necessary to reduce processed food and other things like that.
We don't have to talk about all those issues about do's and don'ts. We're going to get back to those, Doc, because I think the caller is back with us. My understanding is, okay, so we're going to get that call right now who was on with us earlier. Good evening, caller. Thank you so much for joining us on House Calls. Go ahead, please.
Yeah, that's my call.
Yes, you're on. Please.
Yeah. That's what figure you start to say when you need to start to lose some weight? And what figure you use when you say your pressure start to get a bit too high?
Ask the first question again. I think we missed the first question about the overweight. Say again with the first question.
If you'd like to make a call, please hang up and try again. If you need help, hang
What
up
about
and
the
then dial
weight? I think he was asking when do you need to start losing weight, or what's the kind of threshold when you need to start losing weight, and then what are the figures for your blood pressure? You know, the numbers that you gave earlier.
Well, I think I wasn't sure if he was asking whether diabetes can make a person lose weight. So if the person could call back so we can talk. But certainly for blood pressure, the thresholds for treatment for most patients, if the blood pressure is consistently above 140 or over 90. Now, let me just say a few words about, remember I said before that hypertension there's no blood test for it, no x-ray, no EK. So it's really the measurement of the blood pressure. And blood pressure fluctuates quite a bit over the entire 24-hour period between daytime, sleep, etc., work. So one of the things we need to start looking at more carefully is how can we document the blood pressure risk that a person has that includes more readings than just that 1 or 2 readings that you do in the office, because sometimes that reading can be misleading in both directions. It could be overestimating the regular pressure over the 24-hour period, or it could be underestimating it. Frequently, the patients and the doctors think, well, it's overestimating the blood pressure, and then they say, well, it's because I'm here in the doctor's office, that's why it's high. But we need to add a level of sophistication to the measurement of blood pressure so that we get a better idea of what's happening to that kind of patient. So they tell you pressure at home is good, in the office it's high. But
that means that they're worried about going to the doctor. That's the
maybe that's what they think.
Yes.
But there's no way you can know that unless you study the patient more. You need to find out, well, what's the blood pressure at work? What's the blood pressure when they're sleeping? And so there are studies you can do called ambulatory blood pressure monitoring, where you can hook up a automatic blood pressure machine on a person's arm, and it can monitor the pressure for an entire day. That type of machine is much, much better at knowing whether you really have hypertension or not. It knows better what your blood pressure really is, rather than the 1 or 2 readings. Now you're getting 50, 60 readings, and including your readings during sleep.
Yes.
Now, remember I said that sleep is a period of restorative healing. And if your blood pressure, so normally when you sleep, your blood pressure actually drops quite a bit. It can drop anywhere from 10 to 15%. So if your blood pressure during the day systolic, the top number is 120, it can drop as low as 100 or 90 during sleep. And again, that is part of the process of restorative healing. Frequently in persons who are prone or destined or have hypertension, the blood pressure during sleep will remain high. It does not drop compared to the daytime, so that restorative healing is not occurring. So that's why it's very, very useful when you use that methodology in certain patients to know for sure whether they really have hypertension or not. I think patients get convinced when you show them the tracing and they see, wow, look at that, I'm high all this time here, and I thought, I was okay.
You get a complete picture.
You get a graph, full daytime, nighttime. And in some countries, they've mandated that be done for many patients with hypertension in order to be sure at the beginning of the process, the start of the diagnosis, that it's accurate.
Yes. Doc, could you ask you to hold a bit, please?
Sure.
We're going to take another call. Good evening, caller. Thank you so much for joining us on House Calls. Go ahead, please. Good evening. Go ahead, please.
Good evening.
Yes, ma'am.
Good evening.
Yes.
I'm a person of self-growth, diabetes. Sometimes I spend 3 days in the hospital. The question I like to ask, right? How long the diabetes last for? And what kind of diabetes you have?
How long the what lasts for? No, I didn't hear it. How long what lasts for?
Yeah.
Oh,
How long it lasts for?
all right. I think you're listening to your television.
What kind of diabetes?
Okay, we're going to ask you to call back because I think you're listening to your television, so it's creating a delay. We're not quite getting exactly what you're saying. So please just hang up and call us back. We're going to try to, but when you call back, please turn down your television set, please. All right, thanks. I appreciate it. We're going to get some more calls as well. We're going to get Facebook comments and questions as well. Doc, the issue of...
Could I?
Yes.
I believe the caller was asking, how long does the diabetes, if you were diagnosed with diabetes, I believe she's asking if it's a lifelong condition or whether it will resolve. Now, that's an interesting question because in some patients, when they take the right steps and they start exercising, losing weight, they actually can reduce or reverse it. And I have patients who have been able to go off medication who have done that. And so that's a big plus. But the majority of patients, it's very difficult to get them completely over the diabetes. So they have to continue either very high level of lifestyle changes and or medications and nutritional changes.
All right, let's go back to the telephone lines. Good evening. Thank you so much for joining us on House Calls. Go ahead, please.
Good evening, Dr. Mansoor.
Good evening.
Yes. Being hypertensive, is it a possibility that the kidneys could become damaged?
That the kidneys, hypertension,
yes, of course. I mean, the two most common predisposing factors for development of kidney disease are diabetes and hypertension. And that's not just in Antigua. If you pick any country in the world, and you just say, well, what are the causes of kidney failure? It's hypertension and diabetes, no matter which country it is. So they have a particular propensity to cause kidney damage, we know that. In the case of diabetes, we do have a bit of an opportunity to improve and to try to slow it down if it does occur. In the case of hypertension as well, if it's detected, we can initiate treatments that would slow down how fast it deteriorates. Unfortunately, we see, especially with hypertension, too many of the younger men who present very late, where you don't have an opportunity to impact the disease process anymore, and they may need to start dialysis very soon or have a kidney transplant. So, yes, so that's a good question. The kidney can be damaged by both of those conditions, either independently, but more commonly together, because they do sort of run together.
Wow, like siblings. Good evening, thank you so much for joining us on House Calls. Go ahead, please.
Good evening.
Very good evening to you.
I am calling to find out whether or not, what is the symptom? Are there any symptoms of type 2 diabetes? Or you would have to test. Are there any symptoms, any warning sign?
Okay,
thanks. You can look for?
Thank you so much for the call. Really appreciate it. Doc?
Yes, so thank you for that question. It's whether there are any symptoms and signs of diabetes if you have type 2 diabetes. You can actually have fairly elevated blood sugar with minimal symptoms. However, if you're experiencing any of the typical symptoms such as increased urination, feeling tired, weight loss is a common one, sometimes an increase in appetite. You find that you're eating a lot, but you're still losing weight. All those symptoms can be pointers that you may have type 2 diabetes. Other less common, but actually quite useful symptoms would be getting a lot of skin infections and at times having very dry skin because of dehydration. Those can be symptoms of diabetes. However, if you are at risk, if you have a family history, a sister, an aunt, it's a good idea, even if you don't have any symptoms, to be tested for diabetes. And it's a fairly simple test. We're not talking, very sophisticated testing here. It's a very basic blood test you could do at any lab in Antigua.
Pinprick?
You can do it by pinprick in the office or a blood sample at the regular lab.
Okay, all right. Let's go back to the telephone lines. Good evening. Thank you so much for joining us on House Calls. Go ahead, please.
Yes, good evening. I have a question for Dr. Mansoor. Yes, you talk about it is recommended that each family should have a blood pressure monitor. But I want to ask, how reliable are the readings on those monitors? Because I have different kinds. The reason why I ask is because I can remember a few years ago I was hospitalized, and when they use the manual type of blood pressure monitor, when they put on the one with the blue sleeve, you get a high reading. But when they put on the one that has a bigger sleeve with the red sleeve, the reading is more accurate. Can you explain that?
Okay, thank you so much for the call. Really appreciate it.
So let me just repeat the question, since some of the viewers and listeners may not have heard it. The caller is asking about the best ways to actually measure the blood pressure, and he indicated a situation where using one type of cuff, one size of cuff, versus another one gives different readings. So that's actually a very good question. So let's talk about that a little bit. Obviously, if somebody has a very thin arm circumference versus another person who has a much bigger arm, you wouldn't expect that the same cuff would be appropriate for those two arms. Any doctor or nurse would know which cuff to use for a particular patient. If a person is very big, you would need to use a large adult cuff. If they're very thin, you can use the normal adult cuff. The problem you run into is if the cuff is small for the arm, it can overread the blood pressure. In other words, it can give you a reading that is falsely high. And I think this is what the patient is getting at, because with one cuff, the reading was much higher than with the other cuff. So using the appropriate size cuff is an important factor. Now, as far as the home blood pressure monitors are concerned, I would say for the average person, when you buy one of these monitors, make sure that you get the large adult cuff, because it will work for most people in the house, unless there's someone who's very, very thin. If you get the regular cuff, then there may be someone at home who it would be the wrong size. Now, as far as the numbers of how do you know when the readings are off, if you take for home, we would want to consider normal as maybe 130, 135 over, say, 80 at home. So if you're getting readings at home consistently above that, 140, 150, consistently, that's a sign of high blood pressure. So that's when you take your little book that you've been recording them in and take them to the doctor and say, look, doc, here's my readings. What do you think? So
and the doctor might have a kind of open-eyed look.
Yeah, so now they're different. Taking the blood pressure in different settings can be quite different for various persons. Some people feel threatened in the doctor's office, meaning they're in a situation where they may get some bad news or whatever, and their blood pressure may be high. There are other people where the office pressure is actually much lower than it is elsewhere, because they feel safer being in the medical care. This is all happening subconsciously. This is not a conscious, volitional thing. And so getting back to my point that we need to have a lot of different readings being done in order to know for sure what the blood pressure is. A single reading, unless it's very, very high and the person has obvious target organ damage from the hypertension, should very rarely be used. Just one reading. We typically require the patient return again a few days later, a week or two later, to confirm that it is high.
Okay, all right, there you go. So you wouldn't necessarily, like, unlike with diabetes, when you, for example, do one of those tests and say, well, look, you have diabetes.
Yes.
With hypertension, it's a little bit more trend analysis more than anything.
Yes, unless the readings are very extreme.
Okay, there we go. All right, okay, let's go Facebook and then we get telephone lines again. As a question, if the blood pressure rises while at home, what can a person do to immediately reduce it? Blood pressure rises while at home, what can a person do to immediately reduce it?
Okay, well, thank you for that question. First of all, if your blood pressure goes up 5, 10, 15 points, unless you're feeling really unwell, there's no urgent need to lower it. So chances are the blood pressure has been high on and off in the recent past and you just weren't aware of it. Mm-hmm. However, if you're having any symptoms, if you're having any symptoms of a stroke or chest pain or anything like that and the blood pressure is high, of course, you want to seek medical attention for those complaints. Frequently what I see is patients and doctors sometimes, they get scared of one reading, but sometimes it's really not a good idea to try to lower the blood pressure immediately and aggressively because that has its own problems. What one wants to do is lower the blood pressure gradually over a period of a day or two. And so usually what might be necessary is the patient may talk to their healthcare provider, they may take an additional medicine or additional dose of the medicine to bring it down, and then have a reevaluation of the schedule of medications or treatments that they're on. So it's not recommended that one try to lower it. Now, I hear all the time patients talking about different things they do at home, and I can't argue with it because
drink coconut water.
I find that a lot of them do work in lowering the blood pressure because it is something the person is accustomed to doing, and it reassures that person, hence brings down the blood pressure, which is good. It achieves the goal that you want without having any major issues.
Some of them might be psychosomatic, who knows? Let's go back to the telephone lines. Good evening. Thank you so much for joining us on House Calls. Go ahead, please.
Good evening.
Good evening to you. How are you?
I would like to ask Dr. Mansoor a question, please.
Sure, go ahead, please.
I got a friend who woke up Monday morning, right? And one of his eyes, blood red inside. What caused it?
Could you repeat, please?
Hello?
Yes, could you repeat the question? We didn't quite hear.
He woke up Monday morning and one of his eyes, bloody red inside. What could cause that?
You're sounding a little bit distorted because you're probably speaking a little bit too close to the phone. You say you have a bloody eye?
Eyes, blood red inside. You heard me?
No. You said you had red eyes, you said?
One of my friends woke up Monday morning and one of his eyes, blood red inside.
Doc, we're at a loss. We hear you clearly. All right, what we're going to ask you to do is to hang up and call us back because for some reason your line is a little bit distorted. We're not hearing at all what you're saying. So I think that's a challenge. We're going to ask you to hang up and call us back, please. So that caller, 4622996, and we'll ask you to hang up and call us back. Let's go back to Facebook now. Rosalind Best says, the doctor spoke about exercise and controlling diabetes, but isn't a low-carb diet also recommended?
Well, that's a good question. Thank you, Rosalind, for that question. I think that whatever nutritional approaches are taken towards the treatment of diabetes have to be wholesome and complete. Mm-hmm. It's not enough to just say, well, I'm going to go on a low carbohydrate, or low this, or low, so I think that that's where our nutritionists are critical. I see too many patients who, not just here, elsewhere, and Barbados, elsewhere, they've been diabetic for 5-10 years, they've never seen a nutritionist. And I'm starting to pull my hair out. You can see why I don't have any hair. But the truth is that you can't manage a disorder like diabetes without nutritional input. Mm-hmm. And I find I've had patients after they see the dietitian or the nutritionist, they come and say, thank you. I didn't realize really what I was doing because I thought I knew what I was doing, but I really didn't. And so I think that a low carbohydrate diet can be a useful aspect. However, it should be part of a more comprehensive dietary approach to the management of diabetes. Now, I will say that also frequently patients get frustrated by the different advice that we give them, because they may be diabetic, they may be hypertensive, they may have other problems, high cholesterol, they may have some kidney problems, and each of these different areas giving them different advice. It's organ-centric, but not patient-centric. So this is the beauty about the dietitian, the nutritionist. They can see you as a full patient. They see what your issues are, and they can give you advice about a wholesome approach to all these different things. Whereas the one doctor may be telling you what to do for your sugar, another one telling you what to do about your heart, another one telling you. So we have to sort of treat the patient, try to get the information that the patient can use. Because I hear that all the time from patients. They're confused because one doctor told them to cut down the protein because of kidney problem. But another doctor don't cut down carbohydrate, cut down, and then, well, hold on, what am I going to eat? You know,
Because they're wondering.
So it
They
can
might as well just be drinking water.
and this is the beauty of having the integrated, wholesome approach to giving advice. It's not organ-centric, it's patient-centric.
Absolutely, absolutely. Perfect, sage advice, Doc. Let's go back to the telephone lines. Good evening, thank you so much for joining us on House Calls. Go ahead, please.
Hello, good evening.
Good evening to you, ma'am.
sir,
Good
gentlemen.
evening.
Two questions for Dr. Mansoor. One, home testing for diabetic and hypertensive patients. When is the best time to do a test, especially in particular reference to meal times? And the other question for hypertensive patients, should they always take their medication every day, even if you would have checked the pressure and it's within normal but just below normal range? How do you address that? And for persons with limited mobility who might have elevated sugar levels, what sort of exercise do you recommend for those persons, especially arthritic patients and so on?
Thank you so much for the 3 questions. Really appreciate it. Doc will answer all 3.
So let's start with the first one, which is the best time during the day to measure your blood sugar.
Right.
I think it would depend on what type of treatment you're on and how severe your condition is. Certainly, if you are on tablets and your sugar is reasonably controlled, it wouldn't be a bad idea to check your sugar first thing in the morning and record it in your book, and then take it to the doctor when you see the doctor. For patients who are using insulin, I think it's important to measure the blood sugar a little more often. So first thing in the morning is a good idea, and also the minimum would be before dinner. Now, if you are using supplemental insulin for meals, a lot of patients who are on insulin will take additional insulin in addition to their main dose of insulin with meals. They should also be checking their blood sugar before meals, because the reason I encourage patients to do that and to actually adjust their doses according to the blood sugar and to what they're eating is that it's unreasonable to think that every day you're going to be eating the same thing, you're going to be doing the same exercise, so there will be a significant fluctuation in the blood sugar. So having the patient monitor it and then making that decision about how much to take within the boundaries prescribed by the diabetes educator is an important step that can be taken, which now provides a more flexible, adaptive regimen to what the blood sugar is on each of those days.
Okay.
The
second one was about...
Second question was about the...
Do you need to take the medication
do you
if
need
your
to
blood
take?
sugar... If
Yes, so one of the things I realized right away, and I'm very happy you brought this up, is that too many of our patients only take the blood pressure medicine when, according to them, their blood pressure is high. Then you ask them how often are they checking it, and they're not checking it very often. Blood pressure medications don't really work like that. They don't work like an aspirin or a pain medicine. They work because their level builds up in your body, and they work to maintain the blood pressure at a certain point. What happens if your blood pressure today is reasonably good and you take the medication? There's no real danger in that because it just works to maintain that level. When you don't take it that day, the blood pressure is going to increase the next day, so that the next time you take it, it's going to be high. And so you get this up and down pattern when you stop and you start. When you are taking it all the time, there's a smooth consistency to it according to the blood pressure profile for you. Each person has their own blood pressure profile. So I don't recommend that persons do that unless there's an extreme situation. If the blood pressure is dropped quite low and they're dizzy, no, I wouldn't take it. I would just hold it for time being and see how it is later in the day. But certainly, if it's normal, that is not an indication to not take your medication that day.
Okay. Doc, we're going to ask you to hold the third question, and then we're going to take another caller who's been holding. Good evening. Thank you so much for joining us on House Calls. Go ahead, please.
No, but damn it, you're low.
Sorry, go ahead. Hello, good evening. You're on now. Go ahead, please. Good evening, caller. You're on. Go ahead, please. All right, caller is not ready for us. So we'll ask the caller to call us back, 4622996. The third question.
The third question was, we have somebody.
Yes, I think the caller was a little bit distracted. Yeah, hello, you're there now. You're with us.
Good evening.
Yes, good evening to you. Your time. Go ahead, please.
Okay, I would like to ask a question. I had a friend woke up Monday morning and one of his eyes, red blood inside. What caused it? He's not getting any pain or anything, but he just red like blood.
Doc, did you hear the question? I couldn't.
We're
having a serious challenge hearing what you're saying. You should try to be a little bit more.
I got a friend who woke up Monday morning and one of his eyes, red blood inside. He's not getting any pain, but he just red like blood inside.
So your friend woke up. Okay, sorry. You're saying your friend woke up with one of. Yes, you're still there, caller. You're saying.
Can't hear.
You're saying that your friend woke up and one of his eyes was red. Hello. All right. I think it's.
Red blood, yeah.
Okay. All right. I think.
Okay. So
red eyes. I think.
Yeah. So the question really is about a person who wakes up in the morning and their eyes, either one or both are red. Mm-hmm. So that is really not necessarily related to hypertension or diabetes. Certainly, if the eye is visibly red, it could be a number of conditions. As you know, it could be an infection, it could be what they call a subconjunctival hematoma, where just the outside part of the eye there's some bleeding. Frequently, that's because during sleep, the person may have run their fingers over the eye. It's not dangerous in and of itself, and however, if both eyes are affected or if the eyes are painful, they really should seek medical attention because it could be an infection or something else that requires treatment.
Okay, all right. I think we can go back to the telephone lines. We had real challenges here in the first caller. This one should be better. Good evening. Thank you so much for joining us on House Calls. Go ahead, please.
Hello, good evening.
Good evening to you.
One last question.
Sure.
Side effects for medications like metformin for diabetics. Are there any other safer alternatives that you are now recommending besides metformin? I've heard metformin being associated with like dementia and things like that.
Okay, thank you so much for the call. Really appreciate it. No?
Okay, well, there are a lot of different treatments available for type 2 diabetes. Metformin is one of the most popular ones because it has multiple advantages. So it's very effective at lowering the blood sugar to the normal level. Secondly, it promotes weight loss. And thirdly, it has other beneficial effects. Now, no matter what medication one uses or any treatment, there are going to be perhaps some negative aspects to it, right? One has to weigh what the benefit is and what the downside is. Metformin is a very widely used drug all over the world. It's considered first line for type 2 diabetes. Now, that doesn't mean if a person themselves has a reaction to it or some problem with it that there are no other medications. We have many other types of medications that can be used for the treatment of diabetes. And we're very lucky. We have so many different classes of drugs that are available for the treatment, not just for diabetes, but for hypertension. And they are available to us here in Antigua at the drug service at Medical Benefits, which is a huge plus. I mean, I saw a gentleman today who was here from another island, and he had all these medications, but he's not able to tap into it because in his country they didn't have it. And so I think that the availability of treatments in Antigua is excellent. And in the case of a person who cannot tolerate a particular medication for some reason, we have lots of other choices based on the particular problems that person has that we could choose. So I think it's very rare that one can't find a suitable medication for a person with hypertension or diabetes.
Okay, so the person does not have to take metformin if there's a challenge?
No, not at all.
There you go. All right, let's, I think we have one more caller, control room. Oh, Facebook, and then we come back to the telephone lines. So here's a question. I'm not diabetic, but my son was diagnosed with type 1 diabetes at 13. He's now 23. I recently did some blood work and my A1C was 8.2. I checked my blood sugar the following day at the clinic and it was 84. I checked again on 3 different occasions and it was within normal range. What can cause a high A1C and not be diabetic?
Well, that's a good question. I believe she's referring to the fact that her son is diabetic, but she herself has been checking her blood sugar, which is a good idea.
Right.
So I am happy to see that. Well, in this case, what you have is a elevated A1C, but a normal fasting blood sugar. Now, I would say that the fact that the A1C is elevated is a cause for concern, even if the fasting blood sugar is high, and therefore the doctor might be able to do additional tests, for example, a glucose tolerance test. Remember I said earlier that sometimes sugar can be elevated mostly after meals, and that the fasting blood sugar may be normal. You do see patients like that who have normal fasting blood sugar, but their A1C is high. In those patients, I do a glucose tolerance test. In other words, we give them a challenge of glucose and we measure the sugar over a period of time to see how high it goes and how long it stays like that. A lot of the persons who have that disparity, they will have predominantly postprandial hyperglycemia. And there are medications specifically available to treat that kind of problem because the medications are taken with the meals where the sugar is going up high and it doesn't last very long. The treatment lasts for 2-3 hours to cover that period after eating. So that's a very good question. So I would say the doctor is well within being able to do further testing to understand better this discrepancy. There are some other conditions where the A1C may be falsely low or high. So remember I said that the HbA1c is the hemoglobin that is attached, that sugar is attached to. Now, if, for example, you have sickle cell or some other disease that affects the life cycle, the lifespan of the red blood cell, the normal red blood cell live 120 days. In some conditions, it only live for 30 days. So you can see that dynamic will affect the level of sugar that's attaching to it. So some of these conditions may be playing a role sometimes in when there's a disparity between the blood sugar and the A1C.
Okay. All right. So we'll take our final caller for the evening. Final caller. And then possibly just one other Facebook question or comment, and then we'll wrap. So good evening, caller. Thank you so much for joining us. You're our final caller for the evening. Go ahead, please.
Good evening.
Yes, sir. Good evening.
Question: If when I wake with a pressure of 118/73, and I'm on medication, should I take medication or should I hold for an hour or two?
Let me just repeat your question just to make sure everybody here's your question correct. I believe you said that if your blood pressure is 133?
No.
What is it, sir?
118.
118?
Over 73.
Over perfectly fine.
Okay. should I take the medication or should I hold and take it later on?
Right. What I was asking you, though, do you feel fine when the blood pressure is 118/73?
Sure. Yes, sir.
So if you're feeling fine, then yes, just continue with your medication the same way. If you're feeling dizzy or lightheaded, then maybe you could wait until later in the day and repeat the blood pressure and see what it is.
Okay, thanks a lot.
Caller, once again, to your question, you were asking if when you have this reading of 118/73, you hold on or take the medication. Does he hold that second or?
Well, as I said, if he's feeling well, that's a good blood pressure. He should continue his medication. It's only if he's feeling unwell or the blood pressure is a lot lower than that, that he would hold it. And then what he would do is check it later in the day to see what it is. If it comes up, then he could take the medication at that time.
Okay. All right, caller, good to go?
Okay.
Thank you so much. Really appreciate it. Thanks for calling. We
question.
appreciate the fact that our men are calling. And possibly control room, we could just take that last caller who was actually beeping a while ago. So possibly that one. We'll just make the particular allowance for that one. Chris Stevens asks, is earthing, that is walking barefooted, a good therapy used to reduce blood pressure? Earthing.
Well, it's not my area of expertise, so I think you would have to defer to folks who know about that. Certainly, if there's any published, scientific studies on, it would be good to look them up. I don't know the answer to that question, so it's certainly something I will take away to further educate myself on that.
One other quick question in terms of naturopathic, means and so on and modalities. A lot more people are going towards the naturopathic ways. What would be your quick reaction to that?
Well, the naturopathic physicians have a big role to play in management of not just disease processes, but in trying to keep people healthy. And so my approach is always that I will work in tandem with them in terms of trying to get the best result for my patients. Obviously, if I believe that some kind of, advice is being given which I don't agree with, or that can conflict with what the treatments I am providing, then I would make recommendations appropriate to that. It is important, I would say, for patients to always be sure that their doctors, whether they're regular doctors or naturopathic, know what medications they're on or what they're using. Sometimes I sense that the patients may not want the naturopath to know that they're taking medication, and they may not want the physician to know they're seeing the naturopath. So, but I think it's important that we all sort of try to work together to make sure that patients get the best results.
Yes.
Yes.
Okay, Doc, let's take our final caller. Good evening, caller. Go ahead, please. Your quick question, please.
Good evening.
Good evening.
Being a diabetic for quite some time, I notice the times when I have numbness in my fingers and my toes. What can I do about that?
All right, thank you so much for the call, Doc. Numbness in fingers and toes.
Well, I would assume the patient, she's a diabetic.
Yes,
I don't know.
she's
said,
diabetic,
okay.
yes.
And she's having numbness and tingling in the
toes.
fingers and toes. So the most common reason provided, she's had a diabetes for a long time, would be neuropathy from diabetes. That's typically how it would present, first in the toes, and sometimes it'll come up the leg, and sometimes in the fingers. That can be related to two different aspects of diabetes. One is if the blood sugar levels of the diabetes isn't well controlled right now, and that could actually be one of the symptoms. Another possibility is that there could be more substantial permanent injury to the nerves over the years and years of diabetes, and hence that problem may continue for a while. The first type, where it's just because the blood sugars have been high for a short time, that will improve as the blood sugar improves. It can be a very distressing symptom to patients having the neuropathic pains. It can prevent them from sleeping, it can affect their balance, and of course it can affect the health of the feet and cause later on neuropathic problems in the feet.
Yes.
So it is an important symptom that she has raised, and very common.
Indeed. 20 seconds, Doc. what to eat, what not to eat for diabetes and hypertension. I know I put you under pressure, but the line.
No, that's okay.
Yes.
Well, what I would say is, if you are diabetic and hypertensive, the best thing to do is to follow advice that you've been given by your doctor or your nutritionist or your dietitian. As far as possible, eat natural foods. Nothing in a bag or that you have to tear open is natural. The freshest thing you can get in Antigua is something that is planted here. It doesn't have to travel all the way around the world in a container to be labeled fresh. So try to eat local, and it will, a lot of times that will really be a very important step to keeping you healthy. Stay away from ultra-processed foods as much as possible. And frequently, a lot of the fast foods that we eat, they are very ultra-processed. They are not, natural to any extent of the game. So that is my advice to persons. Of course, we have a lot of patients who can seek further assistance. They can go to the clinic, see their doctor, nurses, nutritionists. So these are chronic conditions, and I would really say if there was one thing they would take away today is that it's very important to monitor their conditions. It's not just enough to take their treatments, but it's important to monitor to make sure that their treatments are working.
Sage advice to end, Doc. What a fantastic program this has been. Dr. George Mansoor, as you said, who has been our guest this evening. Extraordinary discussion that we've had this evening. Dr. Mansoor is an internist and specialist in nephrology and hypertension. Extraordinary discussion. Doc, we thank you so much. We would have liked to have been here much longer, but unfortunately we're out of time. In fact, we're way into overtime. We appreciate that. So Dr. Mansoor has been absolutely perspicacious and just so very helpful on this matter in terms of making it very clear and simple and lucid. Next week, take a look at who will be the doctor in the house.
On the next house calls, we zoom in on dentistry. Dr. Sumi Sengupta is the doctor in the house. Tuesday, April 5 at 8 p.m. on all ABS platforms. We will cover all aspects of oral health, including gum disease. Get your teeth into house calls. Tuesday, April 5 at 8 p.m. Brush up on dentistry as Dr. Sengupta gets to the root of the matter. Don't miss it.
Dr. Sumi Sengupta is next. Really appreciate your company. On behalf of our executive producer, Erna May Brathwaite, production assistant, Mary Charles, the control room team who have been absolutely spot on, we really appreciate your company. And of course, by all means, and most of all, thanks to Dr. George Mansoor. Thank you too as well for watching or listening. See you next week on House Calls. Bye for now.